So as part of the HIE, what are the real motivating factors for a practicing physician or a hospital to participate in the HIE?
That's a great question. I mean, the HIE had a promise, and it's a difficult promise to live up to because the HIE is incredibly flexible and incredibly extensible to do many, many, many things. And that's part of the downfall of some of them is not thinking of, okay, what does the provider actually want versus what can I give them? Because they can give a lot of stuff. It's really come down to three things with a fourth thing we'll call a security framework on top of that. One is to access records, and that is kind of traditional HIE function of I have a repository of either data or links to data, and in New York State it's more of links to data, kind of the breadcrumbs to get to this stuff. And that has some utility. It actually has tremendous utility in ED cases where you don't know a lot about the patient when they show up. In transitions of care, it has utility and to learn more about a patient, even though they didn't bring their records with them. But we're seeing even more traction for some of the functions that the HIE can do around that space. The second one is the ability to send records to someone, direct exchange. Really email, something that, it's kind of, you go back to, it's not that long ago, really 15 years ago, that in a corporate boardroom you'd be having a discussion of whether to do email or not. Right? It was, picture in 1997, that debate probably happened. And now you have it, should I do it hosted or my own server? You don't really have a question of, do I get email, do I have a website? That answer's already made. EHR technology is really making that question right now, and we know the answer. The answer is yes, you will exchange. What's really nice is that there's a standard for that now. So direct exchange, national standard, you'll see most HIEs supporting that. Some won't support it directly, so we are building our own HISP, our own exchange model here, the provider directory and the like. Some will say go attach to national networks and they'll support it, but we're actually supporting a New York State-based exchange that will then connect to the national highway.
Okay.
The third is really interesting, and we call this subscribe or notifications or push transmissions, push messaging. It has many names. I like to use subscribe because it fits into three S's that I like, which is search, send, subscribe. And subscription is now the HIE is listening to conversations. And the provider can subscribe or ask this thing to give it notifications about particular things that are happening about the patients that I have responsibility for. So take a primary care provider, take a geriatric provider that wants to know when their patients have checked into the ED or into the inpatient environment, or maybe for follow-up care want to know when they discharge. Things that they really don't know until someone picks up the phone and calls them. And that's one way of doing it, but really a lot of those things get missed, and I do want to do that follow-up care. Same thing on the hospital side. I'm in an ACO or I'm a participant in an ACO, or I need to do coordinated care for CMS or quality reasons. I need to know where my patients are going and seeing other follow-up care to make sure they're on course for the care plan that we subscribe for them, either due to an inpatient stay or a clinical stay as well. And the fourth thing, this fourth S, so search, send, subscribe, and do it securely. And this is the security framework that goes above all that, which has to be in place or else trust drops. And I think the expression we use often here is data moves at the speed of trust. And if you don't have that trust, it doesn't matter. One mistake and it's over. So securely do that messaging, accessing the record that has been done securely. And also we can now use this security framework to extend to other things. Subscription or prescription of narcotics is an example that on a national framework has to be at a higher NIST level, a higher security level. Or we can just use the two-factor authentication, the high level of security that presents in our other functions and provide it to the HR community, to small apps, whatever it is, and the like. So we're seeing a lot of stuff that all really come under the umbrella of care coordination. Right? They're individual, siloed portions of the HIE, but they all fit together to allow providers to coordinate better with other providers.